Good evening, everyone.
Good
On
evening.
behalf of on behalf of Intas Pharmaceutical Limited, I, Dr. Mithilesh Nayak, welcome you all to this 27th episode of Endocrine Talk Show. And today we are going to discuss about very interesting aspect, that is comparison between the empagliflozin and dapagliflozin. So when it comes to the choice of treatment, how can we decide among these SGLT2 inhibitor available in the Indian market? What could be the best way to choose this molecule, and how, in what condition we can go ahead with the one particular molecule, or maybe both are equal in terms of efficacy safety? So what are the difference in terms of pharmacology? What are the difference in terms of efficacy and safety? That we are going to discuss in today's sessions. And to guide us today, we are having with eminent expert from across India. And to moderate today's session, we are having with us Dr. Subhankar Chaudhary, sir. He's a director at Department of Diabetes and Endocrinology at Medica Super Specialty Hospital, Kolkata. So with this word, I request Professor Chaudhary to introduce our faculty for today's program. Over to you, sir.
Very good evening, and welcome to the 27th episode of Endocrine Talk Show. We are, as usual, as in past episodes, blessed by the presence of uh, important members of the faculty who are who's who in their respective fields from across the country. We have none other than Dr. Vinay Sakhuja, who is currently a consultant nephrologist at the Max Hospital in Mohali, and of course he is still emeritus professor at the PGI Chandigarh, where he headed the Department of Nephrology for so many years, and he is of course recipient of so many different awards. So from Mohali, we go to Miraj. We have Dr. Milind Patwardhan, now a consultant. So we had a nephrologist, we have an endocrinologist now who did his endocrinology training from PGI and was a past president of the Maharashtra Endocrine Society. And he has authored books, written many chapters, published articles. So welcome, Dr. Milind Patwardhan. We also have a cardiologist, Dr. Shrikant Shetty, who is senior consultant and head department of cardiology at Sakra World Hospital in Bangalore. He's an expert in transradial coronary interventions, complex angioplasties, intracoronary imaging, and so on and so forth. So we really feel enriched in having a cardiologist with us. And we have yet one more endocrinologist, Professor Demalio Sannal, who is professor of endocrinology at the KPC Medical College in Kolkata. He's attached to several other important hospitals in Kolkata and is currently the secretary of the Endocrine Society of Bengal. So with these, let's delve into our program. SGLT2 inhibitors, we know, made a very big impact in the therapeutic armamentarium in diabetes initially, and soon we found it being embraced even more enthusiastically by the cardiologists and the neurologists. So now it's possibly no longer an anti-diabetic agent, it's more than that. While we have still available in our country 4 of this class of drugs, apart from dapagliflozin and empagliflozin, we still have canagliflozin available, we still have rimogliflozin available, but I think in terms of market share, empagliflozin and dapagliflozin uh, uh, take the lion's share. So we shall talk in depth about these two molecules with the inputs that we get from across the specialties And this assumes importance to us as clinicians as well as to the pharma industry. While we know the usage of dapagliflozin has increased tremendously, the use of SGLT2 inhibitors overall has increased significantly after dapagliflozin went off patent, and we had so many affordable dapagliflozin brands in our country. And now we are on the throes of empagliflozin also to go off patent. So it remains to be seen how much of the space of DAPA is taken over by EMPA, or is it just increasing further space for the SGLT2 class of molecules? So for all our audience, kindly put your questions in the chat box. We shall try and answer as many of them as possible. And we shoot off with Dr. Demallo Sannal, with an endocrinologist. So while SGLT2 inhibitors have made a big impact, GLP-1 receptor analogs also have had very impressive clinical trial results. So in your practice, which has made a bigger impact in diabetes management? Dr. Shanal, please. Please, yes.
Yes, sir. With regards to GLP-1, we also have data, especially with regards to glycemic control, weight, atherosclerotic cardiovascular disease, and also now recently the renal data, especially with the injectable SEMA coming in, the renal data also coming in. So a huge amount of data, as well as with regards to the ESSENCE trial showing benefit in terms of MFLD. Whereas with regards to the SGLT2 inhibitors, we have had a long experience, not only in terms of glycemic control, weight, and blood pressure reduction. Apart from that, significant heart failure benefit, mortality benefit with empagliflozin, as well as CKD benefit, and that has been incorporated by most guidelines. In terms of HbA1c and weight reduction, obviously the GLP-1 fare better, but with regards to heart failure and CKD, definitely the SGT2, as per the guidelines, also score above the GLP-1. With regards to ACVD, probably the GLP-1 has a slight edge in the whole process. Then the SGLT2 like EMPA comes in. So that is the whole position. And with regards to NFLD or MAFLD, it's mainly the GLP-1, which is recommended now even in the guidelines, whereas the SGLT2 is primarily limited with regards to glycemic control in MFLD as well as fat reduction, not reduction in fibrosis or inflammation. So that is the whole perspective which we have. But one, two, three limitations with regards to use of the GLP-1 is one, because of their significant cost. And with the oral GLP-1, the only one which we have available, that is the oral semaglutide. Whereas with the injectable GLP-1, because of them being injectable, the uptake is much less. And also, apart from recent availability of liraglutide injectable, yeah, they are also very expensive. So with practical purposes, with regards to most of our patients, majority we cannot use the GLP-1 option, and we have to depend on the SGLT2 with regards to glycemic control without additional baggage of hypoglycemia, weight reduction, and cardiovascular benefit, renal benefit, and heart failure benefit as well. So probably that has made a bigger impact in our practice, because probably of the simplicity and ease of use and the cost coming down and a huge uptake in our patient population. So probably in most of our prescriptions, they have a place, especially in patients who have cardiovascular or any renal disease. Whereas we
Right.
cannot pass on
Yeah.
this benefit to most of our GLP-1 population, the benefit of
Yeah.
GLP-1 to most of our.
Yeah. I think this will be shared by the other panelists also. So can I ask Dr. Milind, do you feel EMPA has an edge over DAPA in terms of metabolic effects, body weight, lipids, blood pressure, etc.?
Actually, if we see the metabolic effects of DAPA or EMPA as a class of gliflozin, they probably all have similar mode of action and similar type of action also, I would say. It is only in the dose range, that is 5 versus 10, 10 versus 25, that the action can be said to be slightly more with higher dose. But in general, all DAPA and all are similar for metabolic action. The main reason is it acts through sympatholytic activity. That means normally we take increased sympathetic activity to be responsible for cardiac output, hypertension, renin secretion. But it has, I mean, sympathetic activity has metabolic actions, like it increases lipolysis, causes more free fatty acid in the blood, increases gluconeogenesis, and SGLT2 inhibitors being inhibitors of sympathetic activity, they reverse this metabolic effect of sympathetic. And in that aspect, EMPA is supposed to be slightly more potent than dapagliflozin. Similarly, DAPA has more renal actions, which probably Dr. Sokoja will take up, and
Right.
as compared to EMPA. So, considering EMPA and DAPA for their metabolic action, I would say more or less they are equal, but EMPA is slightly more effective because of sympatholytic effect.
Okay.
Interestingly, by
Yeah.
decreasing sympathetic activity in overall organs, simultaneously it causes increase in the sympathetic activity of white adipose tissue, so that the white adipose tissue cells start becoming bright adipose tissue. Bright means brown adipose in white. So they start causing more fatty acid oxidation and therefore more energy expenditure, and therefore weight gain is reduced in experimental mice. So this may go in long way about the weight reduction, which is often an important part of the treatment. So my particular
That comes up, for example, when we talk of DPP4 inhibitors. Similarly, with SGLT2 inhibitors, does the degree of selectivity for SGLT2 versus SGLT1 inhibitor make a clinically significant difference between the agents, between the available agents at least? Dr. Nirmala Shanal,
yeah.
your thoughts? Yeah, please
Yes,
unmute
sir.
yourself.
Yeah,
Yeah.
yes, sir. With regards to, sir, the selectivity of the SGLT2 in terms of SGLT2 and SGLT1, the data, overall data with regards to glycemic control, weight benefit is similar, and especially the cardiovascular data is primarily, but there is one, especially with the sotagliflozin studies showing benefit in heart failure, that may be somewhat additive benefit as well. But because of the SGLT1 have primarily intestinal location, they decrease the glucose absorption from there, and they also stimulate the GLP-1 secretion and inhibit the GIP secretion. They may have added benefit in terms of glucose control, in terms of weight, and especially in terms of postprandial glucose control, what has been also seen with sotagliflozin, especially when they are given in the morning. They have a better post breakfast control, where the breakfast is highest because of highest glycemic excursion, because of the counter regulatory hormones are raised. So that may be an additional benefit, but overall there is not significant, there's not a significant difference in terms of weight, HbA1c, and cardiorenal benefit. We need to probably further explore with regards to HbA1c, weight, and with the combination. Obviously, in our country, we primarily had the canagliflozin, which had some
Yeah.
effect on SGLT1. We haven't had the opportunity to use the SOTA. The canagliflozin, if you remember, had an A1C, sir, reduction, especially the 300 milligram canagliflozin of about 1%, which only crossed the threshold of 1%. And they also, in one of the studies, demonstrated similar weight loss as like a GLP-1.
Mirror.
So with a higher dose. So that benefit is there, and we have used them as well, but the availability and the cost is limited. So that is a problem with regards to the SGLT to SGLT1 combination. But for
Right.
practical purposes, with regards to cardiorenal benefit, they appear similar. They may have an edge in terms of weight and glucose, especially the postprandial glucose control.
Right. Good. So we're back to Dr. Milind. So you also mentioned about doses. Dr. Debala Sannal also talked about doses, of course, in relation to canagliflozin. But if we stick to the ones that are mostly used, dapagliflozin and empagliflozin, what dose do you use, and do you up titrate the dose? And if you up titrate, based on what? Is it because the glucose control was not good enough at the lower dose, so you increase, and do you expect the glucose control to improve, just as we maybe used to titrating the dose for sulfonylurea, for example? So can we similarly up titrate and expect a better glucose control?
Yeah, I understand. See, the trials which were done for cardiac and renal evaluation have used only 10 milligram DAPA or 25 milligram of EMPA. Actually, I did not read about 25 milligram dose there. But DAPA has been used in a fixed dose for cardiac and renal trials. But in diabetes, we also recommend that everybody should start with 5 milligram dose of DAPA or 10 milligrams of EMPA. The important reason behind this is that the patients can experience low blood pressure, volume depletion. They may experience, though rare, acute kidney injury due to volume contraction. So to see the effect of the drug and side effect, it is always better to start with lower dose. And if we really feel that patient is not responding from glycemic point of view, then we can increase the dose. But many times it happens that patients are adequately controlled with lower doses also from glycemic point of view. It is only when patient has underlying cardiac failure or risk for cardiac failure, then we think of increasing the dose. Most of the other time, the same dose with some other drug like DPP4 inhibitor or metformin gives you advantages of two drugs. That means multiple sites are attacked, and at the same time also gives you a better glycemic control. So it is hardly that we keep on seeing HbA1c and then on the basis of that go on increasing the dose of uh, SGLT2 inhibitor for better control, because usually it is in the setup of many other drugs along with it. But when you are considering for cardiac, you have to start with 10 and continue it.
Right. We have already got a question, a very interesting and one of the most important questions from Dr. Shashank, but I think we will keep it for later because we may get some of the answers through the course of our discussion. So we have kept our nephrologist and cardiologist colleagues so far lazy, unutilized. So let's have their wisdom as well. So Dr. Shetty, for CV protection now, would you put one SGLT2 inhibitor ahead of the other, TAPA versus EMPA or whatever, or SOTA is what Dr. Demalushanal mentioned?
So thank you for the question, Dr. Shubhankar. So when it comes to CV protection, SGLT2 inhibitors as a class have shown great promise in the CVOT trials. And all of them have shown some level of CV benefit. However, when you look at the evidence, there may be slightly greater evidence for some of those drugs as compared to others. EMPA, for example, in the EMPA outcome trial, it showed significant reduction in CV mortality, non-fatal MI, and non-fatal stroke as compared to placebo. And CANA also in the CANVAS program showed similar reduction in major adverse CV events, including CV death, non-fatal MI, non-fatal stroke as compared to placebo. DAPA also did not fall short in the declared TIMI 58 trial. It demonstrated reduction in CV events, including CV death, non-fatal MI, non-fatal stroke as compared to placebo. But similar benefits were not seen with ertugliflozin. But one striking difference about the DECLARE TIMI 58 trial as compared to EMPA-REG outcome and the CANVAS program was that the primary MACE outcomes were not reduced in the DAPA trial as compared to the EMPA and the canagliflozin trials. And the major reason for this is the difference in the inclusion criteria. Whereas the DECLARE TIMI 58 trial was more generalizable to a low risk type 2 diabetes population, because it was not mandated to have pre-existing CV disease. In the EMPA-REG outcome trial, most of the patients had established cardiovascular disease, and in the CANVAS program, almost 60% of the patients had CV disease already. So what it means is that when we use SGLT2 inhibitors in patients who are high risk, that means already having established CV disease, the benefits are more robust as compared to when you use it in lower risk patients. And then there was a Swedish trial whose inclusion criteria was similar to the DECLARE TIMI 58 trials, and the outcomes also were similar, and the primary MACE outcomes were not reduced in the dapagliflozin arm. And all the three trials did not show a reduction in myocardial infarction or stroke. So if you look at the available data, it looks like empagliflozin has more robust CV benefits, followed closely by canagliflozin and then by dapagliflozin. However, when we use these drugs, we have to take into consideration individual patient characteristics such as kidney function, heart failure status, and other comorbidities, which also should guide our treatment decisions because we have opposing effects or a more robust effect, for example, in renally deranged patients or patients with pre-existing heart failure. Again, category of heart failure also becomes important.
So, I mean, if I would want to summarize what you said, so you feel empagliflozin is better in terms of the cardiovascular benefits. Is that what you wanted to say?
Yes. Maybe
Right.
marginally better. As a class effect, you see all the three trials showing reduction in CV events. However, probably because of difference in the inclusion criteria, the changes were more robust in the empagliflozin and the canagliflozin trials.
Right. Okay. So, quick question for you. Dr. Jain has written plasma volume contraction and increased hematocrit was considered as key reason for mortality reduction in EMPA-REG trial, though I'm not sure that that's the sole reason. Similar rise in hematocrit was also observed with dapagliflozin. So I think CV death reduction benefit is a class effect. That's Dr. Jain's statement. Although not observed in primary prevention population in DECLARE TIMI 58, what are your thoughts on that? I think you sort of largely talked about it, but would you like to answer to his query?
I'm not sure if that is the primary reason for the CV risk reduction. There are a lot of mechanisms through which, vascular mechanisms through which this class of drugs improve CV outcomes. And like I pointed out, the supposed benefit of empagliflozin or dapagliflozin over dapagliflozin in the primary prevention category is marginal. And then when you choose one over the other, you have to take into account the renal status or heart failure status as well.
Right. Okay. So we now come to Dr. Sakhuja. Sir, we know one of the very strong points that have come out of the CVOTs and subsequently other studies is the nephroprotection effect of the SGLT2 inhibitor class of drugs. And so many different mechanisms are proposed. So what in your mind are the most important that are providing this renal benefit?
I think the most important point that I'd like to make right at the start is that we really don't know exactly how the nephroprotection is achieved. While there is convincing data to suggest that we do achieve nephroprotection, the risk of renal failure is slowed down, it's delayed significantly. There are better survivals as far as the kidney is concerned. There's no doubt about that. But how exactly that is brought about by this class of drugs, we still are not clear. We know that when the drug is first started, there is an initial decline in the GFR of up to about 5 ml per minute. But subsequently, no further decline in GFR takes place, and there is stabilization of the GFR thereafter. So in that respect, this class of drugs resembles ACE inhibitors and ARBs or other RAS inhibitors. So there is an initial decline in renal function, but subsequently there is stabilization.
Now, sorry, sir. Sir, can I just interrupt and ask a quick question?
Yes.
So do you suggest that someone who is put on an SGLT2 inhibitor should have the creatinine checked? And if so, how soon after that? And what will be our cutoff of accepting as normal expectation with SGLT2 inhibitor?
Yeah, we certainly should have a serum creatinine value before we start the therapy. And generally in diabetics, it is recommended that the GFR should be at least 25 ml per minute. The eGFR should be at least 25 ml per minute before you start one of the SGLT2 inhibitors. If the GFR is already below this level, then probably it is too late to start. However, if it is above 25, you can certainly give an SGLT2 inhibitor. And the recommendation is that you can continue these drugs until the time the patient goes on to dialysis or requires a transplant. Earlier, the cutoffs at which this class of drugs was recommended was much higher. But in the latest guidelines, it has been brought down to 25 ml per minute. And it can be continued right up till CKD stage 5.
Right. So you mentioned a drop of about 5 ml per minute as a eGFR drop. So what if there's a drop of 10 ml per minute?
Well, in that case, that would not be very common. But yes, I would like to reduce the dose of the drug. If I've started with 10 milligrams, probably I would reduce it to 5 milligrams of dapagliflozin. Or if I've already started with 5 only, and then of course I would consider even stopping the drug for a while and then trying it once again after a gap of a few weeks. So that is the recommendation also with other RAS inhibitors, that if you have a significant decline in GFR, then you withdraw those drugs.
Okay. Yeah, sorry, sir. I derailed you a little bit from your train of thought. So back to the potential mechanisms of nephroprotection.
The mechanisms, yeah. Yeah, we really don't understand the mechanisms beyond of course, we know that glycosuria is an obvious effect of this class of drugs. How exactly that glycosuria protects us is not known. Because of the glycosuria, there is also some osmotic diuresis, and that may bring down the blood pressure a little bit. It may reduce the tendency to hyperkalemia that can be there in diabetics, and particularly if you're using RAS inhibitors as well. So that's another beneficial effect of dapagliflozin, particularly if you're using it in combination with ACE inhibitors or ARBs. There is some decline in the systemic blood pressure also, but a small decline, not a major one. It's thought that probably the nephroprotection is through actions within the kidney on glomerular hemodynamics, reducing glomerular hypertension, uh, acting on the intrarenal renin-angiotensin system, the intrarenal sympathetic nervous system. So that is where people think that the drugs are acting. But beyond that, we don't really
Right.
understand it any better.
Okay. So we stay with you, Dr. Sakuja. So
Yes.
in CKD, how do you compare EMPA versus DAPA? There are some suggestions maybe EMPA scores over DAPA in diabetes, whereas in those without diabetes, probably DAPA has better track record in terms of various clinical studies. So what would be your sort of advice?
Yes, as you said, in patients, as far as the control of diabetes is concerned, yes, EMPA does appear to be more effective than dapagliflozin in reducing the HbA1c. There is a study, a 52-week study that was done in Korea by Koo and his colleagues, reported in 2019, in which EMPA or DAPA were added to patients who were already receiving metformin, glimepiride, and DPP-4 inhibitors. And they showed that EMPA was significantly more effective in reducing the HbA1c as compared to dapagliflozin. So, yes, so for control of diabetes, there is some evidence that EMPA is better than dapagliflozin. As far as heart failure is concerned,
So let's stick to CKD.
you want to stick?
CKD,
Okay.
yeah.
In chronic, as far as CKD is concerned, there really isn't much of a difference between the two, as
Right.
far as I'm aware.
Okay.
There is one study suggesting that empagliflozin was more cost effective than dapagliflozin. But that may be simply because of
Right.
the cost of the brand of empagliflozin. That's all. Otherwise, no benefit really.
So
No
your
superiority.
message, yes, is largely, I mean, they are similar, right? So
Similar,
we
yes.
come back to our cardiologist colleague. So what about in heart failure with reduced ejection fraction? Would you put DAPA above EMPA? Maybe because in the DAPA heart failure study, it showed reduction of mortality also, or whatever. I mean, I don't want to put words to your mouth.
You already defined the argument over there. So when it comes to heart failure with reduced ejection fraction, both these drugs have demonstrated benefits in reducing hospitalization and in reducing mortality. So they have been a great addition to treatment of heart failure, irrespective of the diabetic status. And if you compare the outcomes in the two trials, the DAPA-HF trial, the primary endpoint was a composite of worsening heart failure or cardiovascular death. And in the Emperor reduced trial, it was a composite of cardiovascular death or hospitalization for heart failure, more or less a similar primary endpoint. And the DAPA trial showed a 26% reduction in the primary endpoint as compared to placebo, and it was a 25% reduction in the EMPA trial. So again, similar. And dapagliflozin reduced hospitalization for heart failure by 30% and EMPA by 29%. Even if there were some differences in the inclusion criteria with respect to the NYHA class or with respect to the coexisting other heart failure therapies and the ejection fraction. Maybe there was a slight difference in the two trials. Still, the degree of benefit seems to be more or less same. In fact, EMPA also reduced the hospitalization for heart failure by 29% and cardiovascular death by about 15%, whereas DAPA reduced cardiovascular death by 17%. So there is a more pronounced reduction in the primary endpoint in the dapagliflozin trial. So and a greater numerical reduction in the cardiovascular death in the DAPA-HF trial, that is 17% versus 15%. So it appears as though while both the drugs significantly reduced the respective primary outcomes, in the DAPA trial, the mortality reduction was slightly better than in the empagliflozin trial. And these differences are marginal, so you could choose one over the other, and you probably have to take into account the coexisting comorbidities, particularly renal disease. So the nephrologist wants to jump to the heart failure part. The cardiologist will want to look at the renal outcomes. So you have to take into account coexisting comorbidities while choosing one over the other.
So just as Professor Sakuja sort of overall would feel that in terms of kidney protection, there isn't a lot to choose between the two. Similarly, for heart failure with reduced ejection fraction, if I have read you correctly, you also feel there isn't a lot of difference between the two. You could pick any one of them,
Absolutely.
right? Okay.
Yes.
So you've can we extend it further and talk about heart failure with preserved ejection fraction? Is that a valid indication yet for use of SGLT2 inhibitors?
This is an evolving area, and actually this is probably one of the most interesting changes that has happened in
and of course the logical next question would be, is there a difference between the two, EMPA and DAPA?
Yes. So hitherto we didn't have any drug class which demonstrated significant outcome benefits in patients with heart failure preserved ejection fraction, while we had great data for ACE inhibitors, ARB, ARNI, beta blockers, and so on and so forth. SGLT2 inhibitors are the first class of drugs which showed great benefit for patients with preserved ejection fraction, and it's not surprising considering their mechanism of action at the level of the arteries and the myocardium and the renal vasculature and so on and so forth, because heart failure preserved ejection fraction is a composite of adverse remodeling in all these areas over time, and both the Emperor preserved and the deliver trial, the DAPA preserved trial showed benefits, but the benefits were more robust in the empagliflozin trial. So empagliflozin reduced the risk of cardiovascular death and hospitalization for heart failure by 21% compared to placebo, whereas in the DAPA trial, this reduction was only about 18%. So while in heart failure reduced ejection fraction, you may be inclined to say that dapagliflozin tends to reduce CV mortality better than what empagliflozin demonstrated. In heart failure preserved ejection fraction, it appears as though, at least as far as what the data shows, that empagliflozin may be better than dapagliflozin.
Okay, right. So there's a question in the chat box. Dr. Arvind has put this question. What about considering dapagliflozin? I suppose now it will be dapagliflozin or empagliflozin in post-MI patients with reduced ejection fraction, but not classified as heart failure in emergency room or in acute setting. I do not know exactly what Dr. Arvind has in mind. Dr. Srikant, would you like to take this question?
Yeah, may I just add a little
Yes,
bit?
sir.
I happen to read that there is probably some role of SGLT2 inhibitors immediately following an acute myocardial infarct. So I'd like to ask the cardiologist to comment on that also.
Right.
Yeah,
Yeah.
so in fact, there are studies already, and this evidence is still evolving. We have to initiate these drugs only once the patient is hemodynamically stable, because acute MI can be a very dynamic situation for the patient in the ICU. Patient may be on inotropes, patient may be in active heart failure. So at that time, we should not be initiating these drugs. So you have the EMPA-HEART trial and the DAPA-MI trial. So the EMPA-HEART trial demonstrated that empagliflozin reduced risk of CV death and hospitalization for heart failure by 25% compared to placebo in patients with acute MI. And here, empagliflozin was initiated as early as 24 to 48 hours after MI, and there was no increase in the adverse events. And in the DAPA-MI trial, it showed that dapagliflozin reduced the risk of worsening heart failure or CV death by 17% compared to placebo in patients with acute MI. However, in this trial, dapagliflozin was initiated at a median of 5 days after MI, as compared to the EMPA trial, where it was started 24 to 48 hours after myocardial infarction. So we can start empagliflozin based on available evidence. You can start empagliflozin as early as 24 to 48 hours post-MI, provided the patient is hemodynamically stable and has no contraindications. And here we would lean a little bit towards empagliflozin because of the available evidence. So yeah.
Okay. Yeah. Good. So we will change tracks a little bit and ask our endocrinologist colleague, Dr. Patwardhan. Combination of SGLT2 inhibitor with DPP4 inhibitor has become very popular and quite effective in achieving glucose control without risk of hypoglycemia. So do you think that inhibiting the DPP4 and thereby suppressing glucagon could interfere with the cardiovascular benefits of SGLT2 inhibitors? Because some of the purported benefits of SGLT2 inhibitors on the heart is reportedly because it raises glucagon a little bit, raises ketone bodies a little bit. Your views?
One thing is, hypoglycemia was not reported in the trials which started DPP4 inhibitor and SGLT2 inhibitor together simultaneously. No much hypoglycemia. But in the trials where SGLT2 was added to a patient who was already on DPP4 inhibitor, that is sequential addition, incidence of hypoglycemia did increase. That is one. And secondly, the hyperglucagonemic effect of SGLT2 inhibitor is much robust than the DPP4 inhibitors' effect on suppressing glucagon. Because in variety of ways, like direct action on alpha cells or by inhibiting somatostatin, which is actually tonically inhibiting alpha cells. So in variety of ways, SGLT2 inhibitors are known to increase glucagon level. So that is not obliterated by DPP4 inhibitor. So some of that will not interfere, the combination will not interfere with the advantages which are attributed to hyperglucagonemia. So in my opinion, there's nothing to worry about that.
Okay, right. So once again, with another endocrinologist, Dr. Demalo Shannan, there have been some concerns raised about adverse effect on the bone of SGLT2 inhibitors, primarily with canagliflozin and also with some studies related to canagliflozin. When it comes to DAPA and EMPA, do you have any concerns? And is one better or worse than the other in terms of effect on the bone, Dr. Shannan? Can't hear. Maybe your internet connectivity is not as. Yes. Sorry.
Am I audible, sir? No.
Now you are. Yes.
Yeah. Yes, sir. With regards to Canvas trial, there was some evidence, there was some data coming up that increase of fracture risk was suggested, but in the Canvas R, this was not there. There was some data with regards to reduction in the bone mineral density in the hip as well in the with canagliflozin, especially the 300 milligram canagliflozin. But as far as data with regards to the EMPIREG trial, the DECLARE trial, there was no signal of increased risk of osteoporotic fracture or change in BMD. So probably with these, in these two trials, with regards to DAPA and EMPA, they are reasonably safe with regards to fracture risk, at least at this point of time. However, one word of caution is very important with all these group of medication is that, especially in elderly population, if there is a postural hypotension, that can increase the risk of fall and that can increase the fracture risk as well. So that is one aspect we need to be careful. But also in elderly females and especially postmenopausal ladies, we need to be careful with regards to BMD monitoring and monitoring for osteoporotic fractures. But as of now, with data with regards to EMPA and dapagliflozin, they have significant data also in the elderly population. It appears to be reasonably safe.
Right. So in terms of bone health, probably there's not much to choose between the two. We come back to Professor Sakuja. So we have this 65-year-old obese lady who's got type 2 diabetes for last 8 years. A1C is a bit elevated, 7.5%. She's already on metformin and sitagliptin, and she has a history of recurrent urinary tract infections. Would you be happy to add an SGLT2 inhibitor? And is there any preference between the two? And we have also a question in the chat box from Dr. Krishna Rao, whether incidence of UTI, EMPA versus DAPA, are there any differences in safety?
Right. Yeah, so the main issue in this patient is the history of recurrent UTI. That is the main question as to whether an SGLT2 inhibitor would be a suitable drug to use in that kind of setting. If there wasn't that problem of recurrent UTI in this patient, I would have absolutely no hesitation in adding this drug or using this drug in this 65-year-old obese lady to improve the glycemic control. Now, coming to the question of urinary tract infections. Now, in the earlier reports, soon after the introduction of these drugs, there was an FDA warning also that these drugs could increase the risk of urinary tract infections, and therefore one needs to be careful in that setting. And the increased risk of urinary infections was attributed to the glycosuria. And the glycosuria was also related to the dose of the SGLT2 inhibitor. So if you're using a larger dose, you'll have more glycosuria. You're using a smaller dose like 5 milligrams of DAPA, you'll have lesser glycosuria. However, in a large study in which more than 3,000 patients were included, discontinuation of DAPA because of UTI occurred only in about 0.3% of patients. So it was a very, very low incidence. And the subject has been addressed in a review article in Kidney 360 by Wigley et al. In 2022. And they have concluded that there is no increased risk of urinary tract infections with any of the glyphosins. So you can use them now even in patients with recurrent UTI. I won't hesitate to use them. Yes, at the time of starting the drug, I would ensure that the patient doesn't have an active infection at that time. If there is an active infection, I would delay starting the drug until the infection has been treated adequately. And yes, if there is a bladder outlet obstruction or a neurogenic bladder, these are situations where the risk of infections would definitely increase. Yes, there I would hesitate to use this class of drugs. But simply recurrent urinary tract infection without any predisposing factors in this elderly female, I would not hesitate to use SGLT2 inhibitors. Yes,
Right.
during an active infection, I would withhold the drug. Yes.
Right. Can I have a quick response from our endocrinologist colleagues, Dr. Patwardhan and Dr. Shanal? What would you do? Would you use in this lady an SGLT2 inhibitor?
I will not use.
I will not use. Shanal, Professor Shanal, maybe he's having connectivity issues. Right. So,
Secondly,
uh,
what I would rather add that patient of 65 years having a HbA1c of 7.5% is okay control. There is no need to add anything at this time.
okay. We make it 8% for you.
Okay.
Once
I'll
is
think of
8%.
something else.
Okay. Right. Okay. Dembalu, you are there now.
Yes, sir.
Did you get the question?
Uh,
The
Sir, could
previous
you
question that was
repeat the
addressed
question,
to,
please?
yeah, in someone with recurrent history of recurrent urinary tract infection, were requiring something to improve the glucose control, would you add an SGLT2 inhibitor?
Sir, I would be very hesitant with regards to adding an SGLT2 inhibitor if a person is having a recurrent UTI or upper urinary tract infection. These are the two areas where I would be careful. It is not with the GTIs which is worrisome, but with the recurrent
Yeah.
UTIs and the upper urinary tract infection, it is something which may be worrisome. So I would be hesitant to start SGLT2 inhibitor in recurrent UTI, not with the first episode of UTI, but with recurrent UTI and upper urinary tract infection like pyelonephritis, sir.
Right.
And there
Okay.
was one study with regards to the Vertis CV study among all the CVOT studies, which had showed
Yeah.
an increase in UTI levels apart from the GTIs
With orthogliflozin.
with ertugliflozin. Yes, sir.
Yeah. Okay. So we should be winding up in a little while, but we have quite a few questions in the chat box. I'm trying to figure out which one to be addressed. So let's ask Professor Sakuja in relation to AKI. Initially, when the SGLT2 inhibitors were launched, there were some concerns that acute kidney injury is increased with this class of drugs. Subsequently, possibly it's been shown that they are actually happening less often in SGLT2 inhibitors versus non-users. So is there a difference between the two, whether it's on the good side or on the bad side between DAPA and EMPA?
Yes, you're right that in the beginning, when these drugs were introduced, AKI was mentioned as a side effect of these drugs, and so it was considered important to monitor the serum creatinine and the GFR soon after the start of the drug, and in case there was any episode of AKI, then you should withdraw the drug. This was the recommendation. However, subsequently, in more recent years, it in fact has been shown that the frequency with which AKI develops in users versus non-users, the frequency with which AKI occurs has reduced in patients who are on SGLT2 inhibitors. So the only precaution to be taken is that in a patient who is already volume depleted, since SGLT2 inhibitors cause an osmotic diuresis, in such situations, you should avoid the use at that point of time. But in all other situations, there is no need to be afraid of the development of AKI when you're using these drugs now.
Yeah, that's reassuring. But and you are not bothered whether it's EMPA or DAPA,
Yes, it doesn't make a difference.
right? Good. So we have a question which is, I don't know, for the cardiologist, for the nephrologist, maybe for the cardiologist. So Dr. Agarwal asks, can we give SGLT2 inhibitor in CKD5 patients with heart failure with reduced ejection fraction or for CV protection, if not for nephroprotection?
I think they're contraindicated in stage 5 CKD, if I understand it well.
To initiate, yes. I mean, generally it's not yet recommended. And I think the reason for that is there isn't enough evidence in that class of patients, right? Okay. And this is a rejoinder, sort of a response from one of our members of the audience, Dr. Roy. It was mentioned earlier that HbA1c reduction is better with EMPA than with DAPA. And he is clearly not impressed with that. And so he wants to know what is the difference, what is the amount of difference between the two? Would anyone like to respond to that?
I agree with the questioner that there is no difference between EMPA and DAPA in their glycemic activity at appropriate doses.
Okay. Right. And then there's a question from Dr. Agarwal. In DAPA CKD trial, the benefit was seen when urine ACR was more than 200 to 5,000 milligram. Does the benefit accrue in patients with? Yeah, that's the other important question. In non-proteinuric CKD patients, do we still see the benefits of the SGLT2 class of drugs? And there are some extensions, Dr. Sakuja. Can we use them in IgA nephropathy?
Yes.
Or
Yes, this is
adult polycystic kidney disease?
Yeah, this is an important question. So there is now sufficient evidence to suggest that these drugs are useful in non-diabetic kidney diseases as well, but the evidence is restricted to proteinuric non-diabetic kidney diseases. So I would use it in patients with focal segmental glomerulosclerosis, membranous nephropathy, IgA nephropathy, membranoproliferative glomerulonephritis. In other words, all conditions with significant proteinuria and CKD. However, the evidence is not yet available in non-proteinuric CKD situations. So, because it really hasn't been studied in that situation extensively. So I would not use it as yet in polycystic kidney disease.
Right. And so of the proteinuric non-diabetic CKD, do you think there's one SGLT2 inhibitor that scores over the other?
No, not really. Not really.
Right. So once again, it's there's not much of difference between the two. So maybe the final question for each of our panelists this evening is, if the EMPA, which will now be launched by maybe 50, 70 companies in our country, were to cost similar to DAPA, would you change from DAPA to EMPA, and why? So can we start with Dr. Patwardhan?
Yeah, in patients with high risk of heart failure, I will change to EMPA because it has been shown to have more effect both in heart failure as well as cardiac mortality, all-cause death, and as well as ischemic events also. So it appears EMPA is slightly better than DAPA in cardiac patients. But if it is not that much
benefit in heart failure, okay, but anyway, so in for cardiac benefit, you would put EMPA ahead of DAPA. Okay, Dr. Shrikant Shetty.
Yeah, I think as rightly pointed out, in heart failure, EMPA has a broader indication because it is robust in both heart failure reduced ejection fraction as well as in preserved ejection fraction. Whereas DAPA is probably better in heart failure reduced ejection fraction. And cardiovascular mortality in the CVOT trial, but then again, I will qualify it by saying that the inclusion criteria were different. The EMPA trial at least demonstrated a more robust reduction in cardiovascular mortality as compared to the DAPA trial.
Okay,
and,
okay, no, please finish. Please complete.
And as far as heart failure hospitalization is concerned, EMPA showed a greater reduction in heart failure hospitalization, which is a very important consideration. And anywhere, and particularly for our patients, because heart failure hospitalization is associated with significant morbidity, cost, and with every heart failure hospitalization, mortality also goes on increasing. So, which should be a very strong consideration in patients with chronic heart failure. And anti-atherosclerotic benefits are supposed to be a little more robust with empagliflozin as compared to dapagliflozin. So if the cost is the same, maybe for a broader range of indications, EMPA may be a better choice as compared to DAPA.
Right. This must be sweet to the ears of the pharmaceutical industry who are waiting to bring in various brands of empagliflozin. But and on this point, I mean, our endocrinologists and cardiologist colleagues have agreed. So they feel EMPA has some edge. Though, of course, we have all agreed that there isn't a great deal of difference. I'm sure even Dr. Milind and Dr. Shrikant agrees to that. But so now let me put the next question to the first two respondents. So let's say, because you feel EMPA has an edge, so would you be okay if the pharma brings in EMPA at 50% excess cost over DAPA? Would you still be going for EMPA because it's got greater value? I mean, this is a hypothetical question. I do not know what their pricing strategy is.
I'm not sure.
They
I
don't
would
bother
want
about prices. Cardiologists don't have to bother about prices.
No, I mean, there are there are drugs with great differences and there are subtle differences. So I'm not sure if we are doing such great difference over here that I would switch from.
Fair enough. Maybe it was not a fair question, but still, Milind, would you like to respond?
Yeah, I also agree with Dr. Shetty that it is not a very big difference. And I would stick to the same drug if patient is already on it and continue it.
Right.
Yes, sir. I also would not shift from DAPA to EMPA, especially if the only one case if the patient has atherosclerotic cardiovascular disease established ASCVD. Other than that, there is absolutely nothing, no difference. And probably one area could be non-proteinuric CKD, where the EMPA CKD trial had some data with non-proteinuric CKD. Otherwise, there is nothing to choose, especially no point in shifting one agent to the other. While initiating, probably we can choose agents. And especially in CKD, probably there might be some benefits with regards to CV death with dapagliflozin. That may be one aspect to consider. And for primary prevention, probably dapagliflozin may have an edge because of data in the declared study when we are starting a therapy. Otherwise, no point in changing, sir.
So when you start, so which is the group that you would start EMPA and which is the group that will start DAPA?
So in patients who have ASCVD or even with ASCVD or heart failure and non-proteinuric CKD, EMPA would be preferred. And in patients who have proteinuric CKD, we can choose either. Probably DAPA has an edge, and primary prevention probably DAPA has an edge. Means in terms of data, no difference really in clinical practice, but with regards to data.
Right. And so we finally come down to Professor Sakuja for your wisdom.
I think Dr. Shubhankar has done an excellent job of moderating the discussion. Just one last comment that I would like to make is that when we have sometimes prescribed this drug, dapagliflozin or empagliflozin, to non-diabetics with, say, proteinuric chronic kidney disease, what has often happened is that a chemist or a GP has told the patient that this is a drug that you use for diabetes. Why are you taking it? You are not a diabetic. And then the patient doesn't start the drug or stops taking the drug. So I think patients should be warned in advance. Such patients, like if you have a non-diabetic with heart failure whom you have prescribed this drug, that would be for the cardiologist. The patient and his family should be warned that this is a drug that is used for control of diabetes, but in your case, we are giving it for a different indication. That needs to be made clear in advance. Otherwise, it's very likely that because of somebody else interfering in his treatment, he will not take the drug or stop taking the drug. This has been
Right.
my experience.
Absolutely. Thank you, sir. So I think we should try and wrap up. We have had excellent inputs from all our panelists. And Dr. Rastogi has put a final question that overall benefits of both molecules are similar. So, in my opinion, that's Dr. Rastogi's opinion. Unlike teneligliptin versus sitagliptin, where evidences are lacking, here both molecules can be used in all approved indications. What are your thoughts? I think you have been, if you have been following the discussion closely, should have got the answer that largely you could use one or the other, but there are subtle differences and maybe there is subtle potential benefits of empagliflozin over dapagliflozin. But in my view, since I'm moderating, maybe uh, like all the others who have put in their viewpoints, I feel the differences between the two are not great. We would still like to make use of this class of drugs, and there is great potential of wide use of this class of drugs, whether it's EMPA or DAPA. So with these, I would like to thank profusely Professor Vinay Sakuja, Dr. Milind Patwardhan, Dr. Srikant Shetty, Professor Devmallo Sannal, and of course the entire INTUS team for providing us a platform to discuss such interesting issues with our physician community. And of course, all of you who have joined in, and I have not got the numbers, how many of you have joined?
Around 2,400.
Right, now I've got, and it says almost 2,500 doctors have joined. It shows it has been an important issue that they also want to learn from and learn about and to make their own decisions in future. So thank you, INTUS team as well. And it's back to the organizers.
Thank you, sir. So it is truly an honor to deliver the vote of thanks. First and foremost, I extend my heartfelt gratitude to our esteemed speaker, Dr. Sanyal, Dr. Sethi, Dr. Patwardhan, and Dr. Sakuja, sir, for sharing their valuable expertise and profound insight this evening. Your wisdom has not only enlightened us, but also provided practicable and actionable takeaways that will help us in deciding the SGLT inhibitor in clinical practice. A heartfelt gratitude to our course director, Dr. Chaudhary. As we reach this 27th episode, the enthusiasm and active participation from our audience remain as strong as they were in the very first session. All the credit goes to remarkable consistency engagement of our course director, whose leadership and guidance is enlighten us in every episode. I would also like to express my appreciation to our incredible audience and impressive 2,400 participants for their active participation and engagement. Lastly, a heartfelt thanks to our tech support team because they are the behind all these flawless executions. And lastly, thank you to all of you for your invaluable support and participation. And we eagerly look forward to your presence in our future episodes. Till then, take care. Good night, everyone.